Hey guys, it's Meg Collins with Lucy'sList.com. Today we're here with Allison Romero. She was my pelvic floor therapist, and we are discussing a topic that I have been wanting to discuss for 5 years. Literally, it's been on my agenda for a good 4 to 5 years. So I wanted to discuss problems with the pelvic floor, postpartum. I want to discuss pregnancy. I want to discuss all that. So, without further ado, we're just going to sort of freewheel it here for a while. I wanted to sort of just open up with a general discussion about what happens to the pelvis during pregnancy and postpartum, and then we'll talk about all the things that can go wrong. Yeah. So I'm just going to sort of turn it over to you, and we'll just sort of chit-chat about it.
Okay, so in pregnancy, pelvis changes. Around the second trimester, we start getting some relaxin going through our body, which is a hormone that starts to loosen the ligaments, right? So pelvis isn't moving that much in the second trimester, but it's starting to like prepare to be moved. In the third trimester, so starting at about like 28 weeks, something like that, the ligaments start to really relax, okay, in the abdomen and in the pelvis as well. And the pelvis actually does start to move. And so that's where we start to see pregnant people start to waddle a little bit. It's harder to like get up, down, just because, obviously because of size, but also because you don't have the same support.
Is round ligament pain related to that?
No, different. So round ligament pain is the ligament that attaches the uterus to the abdominal wall, and so that we usually find in like the second trimester when you're growing.
Yeah, that's earlier.
Yeah, and that's just like new stretching movement that you haven't felt before. But so relaxin is more about the ligaments that are attached in our SI joint, the sacroiliac joint, or just around the pubic symphysis and the pelvis. That kind of thing. So the pelvis starts opening right from the front. And compressing in the back a little bit more to prepare the vagina for birth.
We're going to say vagina a lot.
Yeah.
So, hope you like it.
So that's pregnancy.
Yes.
So then during birth, right, so during birth we're going through, the uterus is contracting, the vagina is getting ready to open because the cervix is dilating, and so then we get the baby out.
Push our baby out.
Either, vaginally, or I guess C-section is the other option, but usually it's vaginally. And what happens there is our pelvic floor has to lengthen like 2.5 times its normal length to get the baby out. So a lot of times that's where injuries can occur.
So let's define the pelvic floor.
Yes, let's define the pelvic floor.
So I was always told as a visualization, as a layperson,
yes, that
the pelvic floor is like the bottom of the grocery bag that's holding your groceries in. Your groceries being your female junk. Is that accurate?
Interesting. Yeah. So the pelvic floor is a group of muscles that attaches from the pubic bone to the tailbone, essentially, and it looks like a hammock, right? It's the bottom of our core. So I think of it as the bottom of our core. So the diaphragm is the top, our abdomen, our abdominals is the front of the core, our back, and then our pelvic floor
is
the bottom of the core. Right. So that's what the pelvic floor is, and it has 3 holes in it, right? For women, it has the urethra, the vagina, and the anus. Right. Okay, so it's supporting the organs, it's supporting all of our organs, our intestines, our uterus, our bladder, that kind of stuff, but it also has, holes in it. Right. As like natural points of weakness, but we need them to like pee, have babies, poop, right? Right. So that's what the pelvic floor.
And so you were saying during delivery, the pelvic floor.
So during delivery, that pelvic floor, the perineum especially, which is the muscle that goes right between the vagina and the anus, is going to lengthen like 2.5 times its normal length.
Gotcha.
And that's totally normal, and our body knows how to do that, but it does, but it doesn't. There's a first time for everything. Right. So often, especially with the first, we get some injuries. We can get avulsions of the muscle, so the muscles can actually like pull off of the bone, and it happens in like 2/3 of vaginal deliveries. Really? And we don't do anything about it because we just don't. Let's see, and then the other issue is we can tear in the perineum. Right. Usually we do. if it gets past a certain point, then it becomes a bigger issue down the line, right?
So I know few people, and once you have babies and you talk about delivering babies with your friends, you hear about very few people who don't tear at least somewhat during delivery, even if it's a minor tear. So that's just kind of normal, right?
Totally normal.
Yeah.
So this is why we've sort of shied away from episiotomies, though, or at least it's not trendy to do them now, because what we're thinking is, if you had a piece of fabric, right, and you pulled, you might get a tear,
right?
But it would only tear so much, and it might be, it would just tear in the natural weakness,
right?
Whereas an episiotomy, they're just cutting through, and so it's just easier to tear, right? Same with fabric. If you were to cut the fabric, it's easier to tear the fabric,
right?
So most people tear 1 or 2 levels, and that's when we grade it through sort of levels of skin. So there's the vaginal mucosa, which would be just a stage 1. That's such a little tear. Stage 2 would be into the muscle a little bit, and then when we get into stage 3 and 4, that's going into the anal muscle and sphincter and mucosa that way, and that becomes a bigger problem.
Right. Now, are we talking surgery for the higher level tears, or?
They'll stitch you up, and then we see where we're at kind of down the road.
Okay.
Gynecologists are really trying to avoid these tears. If people get a level 3 or 4 tear, they often need to present in front of a board at the hospital, why that happened.
Oh, so that is not a good outcome.
It's not a good outcome. It happens more often with forceps deliveries or vacuum-assisted deliveries, and it can cause major long-term incontinence down the road.
Right. And are we talking that's pretty rare, or?
On the rarer side,
okay.
Not rare by any means.
Not as rare as we would like it to be. Nobody wants that.
Nobody wants that.
Yes, I know someone who had a level 4 tear, and I think she's permanently sort of impaired. So we'll discuss sort of the problems of. Well, let's stay with pregnancy real quick.
Yeah.
And we'll go sequentially. There is sort of a term out there called perfect pushing, and I had asked you on one of my appointments, is that a thing? Is there a way that you can push your baby out that's better than other ways?
Right. And my answer to that is, I don't operate in a world where there's a perfect pushing, but I think, mother-led pushing or whatever, that's not really the real term, but
versus a doctor telling you.
You tell yourself what to do, right? So if you feel like you need to be squatting, that's a good push for you. If you feel like you need to be on all fours, that's, for you.
Your body knows how to position
lying
yourself.
On your back with your knees up, like we see in the movies, is really not perfect for most people. And I think, in some states it's more common that they really want you to be in that position because that's just the way it's always been.
Right.
Seems like in California we're getting more away from that, and they're giving birth bars and birthing stools and stuff like that.
But I will tell you, it's still pretty traditional at the hospitals around here.
I saw a woman from Alabama, and it was you must be lying on your back pushing with your knees up. That's
no
just
option.
the way that they do it. So, and that
in a hospital,
that's a problem. Yeah, because like I said, birth is something that our body knows how to do. We've obviously been doing it for since the beginning of human time, but it's not this black and white thing. So pushing, I think, needs to be something that you kind of intuitively find.
Okay. That's a good answer. So not really, I think, is the answer.
Not really.
You don't have to study up on some technique.
Yeah. Well, and just one last thing about that is I think sometimes we forget or we don't know how to push, and maybe that's what, that's part of that technique. But so making sure that we know how to push, if there's any question, that would be a good time to check with your physical therapist, something like that, to make sure you just know how to lengthen your pelvic floor. Sometimes people don't know how to do that.
Right. Okay. Or they're afraid to.
They're afraid to.
So let's talk about sort of the big problems that you see from your patients who come into you after they've had a baby. Now, I came to her 4 years after I had given birth, which, again, it was on my list of things to do. I was having problems with incontinence. I could no longer jog or jump or do anything with impact. And so I came to Allison. I didn't really know what she could do, if anything. So I think incontinence is probably the big problem.
Yeah.
So, but what are the other problems that can happen during childbirth?
Through this process, yeah. So incontinence is a huge one. So there's urinary incontinence, there's fecal incontinence, which comes into play usually with more of like the level 3 or 4 tears. Prolapse, right? So that's when we get like a softening sort of the ligaments that hold the bladder or the rectum or the uterus.
And they don't go back.
And they don't go back.
Right.
And then there's pain is another one that can be an issue. So some people have pain with sex.
Right.
Some people have just pain.
Or sex is different.
Sex is different, yep.
And then there's diastasis, which I also had.
And diastasis recti.
Which is an abdominal separation. And I actually thought I was under the initial impression that was purely cosmetic, but in fact can be problematic, right?
Well, like I was saying earlier, that, the pelvic floor is a part of our core. The rectus abdominis is a part of our core too. So the rectus abdominis is the muscle that looks like a six-pack, right? We've seen.
I mean,
I've never seen it on myself either, but I know it's there somewhere. So in 100% of pregnancies in third trimester, we get a diastasis.
Right.
That we're meant to do that. Now, whether or not it goes back is the question.
Right.
And for some people it does, and for some people it doesn't. And then we've got two sides working separately,
right,
and not communicating. And so if you think, like, they're a huge support of our bladder in the front. So we need them there to be, strong to keep things...
To be connected, or at least to be close.
We need them to be working in conjunction. We need to be able to generate tension through those muscles to, like, support...
And that's something I still...
We're working on it.
We're working on it.
And it takes a while, right? It's been 4 years, so then it takes time to get... It takes a minimum
speaking of
like
timing, when should a mom come see someone like you?
Okay,
What's the ideal sort of...
Well, it depends on if we want to talk about pregnancy. Do we want to talk about, like...
So postpartum.
Postpartum, okay.
Stuff has happened, something's not right.
Okay.
Your OB is not giving... We'll talk about traditional medical care and how it gets overlooked a lot, especially in this country. But, so say, like, the incontinence is not getting better.
Yeah.
Or there's just something isn't right. When would someone come see you?
At the earliest, I would say come at 8 weeks.
Okay.
Come 8 weeks. Things don't feel right.
Because part of that, things are still going back into their...
Exactly. I mean, it's a big deal to have a baby, right? It's like, I consider it like a surgery. I mean, it's like, it's a huge change to your body, and your body has to get over it.
Right.
And so around 8 weeks is when I feel comfortable assessing the pelvic floor, right? And so that's when I would say that's the earliest to come in. Okay. If you are leaking then, come in, let's look, let's see what's going on. Are your muscles, like, I said they stretch 2.5 times their normal length, so it's like, did they stretch out so much and then tighten up because that was like a huge kind of scare to them? Or did they stretch out and then stay that way? Do we need to strengthen them? And the earlier we can fix it, the earlier it goes away, the earlier your body forgets about it.
Okay, so definitely in the first year if possible?
Yeah, I would say in the first year if possible.
Okay, that's good to know. Maybe for the next life, I can remember that.
And then there's like life, and you have to have you raise your child and do all that other stuff. But if you can fit it in, I would say the sooner the better.
Okay, so at I think I had a 6-week appointment, and then I had like another appointment down the line with my OB, and I mentioned to him, and he was a phenomenal OB, and I said, look, I something just isn't right. I'm having problems with bladder control. When I sneeze, when I cough, I pretty much can't do any sort of jogging or, anything really. Even bouncing hard down a hill. Yeah. And he says like, It was kind of like this sort of, that's weird.
Yeah.
Sort of reaction. So I really thought, gosh, maybe something is just wrong with me, and this isn't a thing, and I'll just have to live with it. Like, this is just something bad that's happened during, wish I had a C-section. I don't know. I just, was sort of like a little dismayed. But then when I started talking to people, and they were like, we're going to go jogging, and I was like, I can't, because, and they're like, well, you got to go see so-and-so. And I'm like, what? What? Who? And it was, and everyone else chimed in, yeah, you can, everyone has that, and you got to go. And I was like, well, okay. So it bumped up my priority list. And, but I think that a lot of OBs in America don't know, or they don't.
Yeah.
they just don't address that with their patients postpartum, and that is a real shame, because if you talk to European women, they will almost always tell you, oh no, I had to meet with someone in the hospital before I could be discharged, and we had therapy afterwards, and it's a regular course of events for them to do that. And here it's like the secretive thing. So do you have anything to say about that?
I wish it was more mainstream. I mean, like I said, it's like you have a surgery, you get PT, you work on your body, right? Because things have been disrupted.
Right.
And so not only are you pregnant for 9 months, and that is in and of itself a big deal to your body, but then you have the baby, whether it is vaginal or C-section, there's been changes, right? So what I don't want to speak on behalf of all gynecologists out there, because there are so many that refer.
Do know.
And obviously in the Bay Area, I feel like we're getting there with that. But what I've gleaned from the gynecologists that I've spoken with is that they kind of learn the muscles in med school, and then that's the time that they learn, and then they go into their residency, and they're really not talking about that anymore. They're talking more about cervical things or uterine things or vaginal
specific sort of procedural
things that are very procedural, and so they're not talking about the muscles as much, and I think they sometimes go by the wayside.
Yeah.
And they're not talking about referring to physical therapy.
Right. And I think that is the case more so the rule than the exception.
Yeah.
Hopefully that's changing as time goes on and as people sort of become better educated about these things.
Yeah.
So I'm so glad to have found you. I am on the mend, I would say, and I hope to be able to. I asked her sort of what's the gold standard? Am I ever going to be able to jump on a trampoline? And
you will.
Maybe.
You will.
Yeah.
Yeah, it's
jumping on a trampoline,
but that is the gold standard.
I mean, I actually know very few moms who can do that without a little bit of leaking. And if you're one of those moms who's like, I can do that, you're lucky. Trust me, you're lucky. Yeah. So let's focus on the incontinence here for a minute. Is there a percentage of women who...
Oh my gosh, it's something like 38% of women are incontinent at any one time.
Just at any given time.
So if we just took a snapshot, it would be 38%. After after childbirth, gosh.
And of course it gets worse as you get older.
And so
it's not treated.
Exactly.
I mean, everyone knows their family members who perhaps use poise a lot, or just it's a thing.
It's a
older
thing.
Folks,
it is. So and that's one of the hugest thing. That's one of the hugest reasons people end up going into assisted living, or that kind of thing.
It becomes a lifestyle problem.
So it's something that is fixable, and we want to fix early.
So these generations of women who never got help, it's kind of sad. Yeah. Because it needn't be that way.
Yeah. Yeah.
I'm sure obesity adds to that, and
it does.
Just other lifestyle problems that tend to develop in age. So
I don't have a hard and fast percentage after pregnancy for people that deal with incontinence, but it is a lot of women at any given time. 38% is a lot of people.
Sure.
Or, so it's very common, and for some people it goes away, and for some people it doesn't. So, like I said, that's why if it's there and it's been a couple months after you've had the baby, it's worth checking in.
Yeah.
And
I asked you at my appointment, is it because I'm older that, I was in my mid-30s at the time, and
it's not. No, age really doesn't have anything to do with it. I mean, it's genetics is the number one thing that they're finding has something to do with it. So if you have moms, sisters that have had kids and have the same thing, it probably will happen to you, right? And a lot of it has to do with our ligamentous laxity. So that means how mobile we are, how flexible we are.
Say that 3 times.
Right? Yeah. So for people that are you really flexible?
I used to be.
Yeah,
but not
particularly, but just women tend to be more flexible anyway because we have babies, we need to be able to stretch. But then people that tend to be extra flexible are the people that
tend to have problems, or
tend to have problems.
Oh, do have problems.
Yeah.
Okay. So when someone comes to see you initially, I know that there are some hang-ups maybe about the intimacy of what's going on.
Sure.
Because it is very intimate. And what I would say about that is it's no worse than going to your OB for a vaginal exam.
Yeah. It's not, I don't think it's on anybody's like favorite thing to do, but do you want me to just kind of go
Yeah,
through,
just kind of step us through.
So if you know, a typical kind of first time appointment would be you come in, we talk for, you know, maybe 15 minutes about what's going on, and then I would have you undress from the waist down. And then you're covered, right? But we're just undressing from the waist down so that we can look at the abdomen and we can look at the muscles that attach to the pelvic floor externally, and then we can look at the pelvic floor internally. Usually that's vaginally. So if people have any kind of anal stuff going on, we will check rectally, but usually we check vaginally, and that way we can check the bladder, we can check the rectum, we can look at the urethra, we can look at the strength,
everything,
perineum, everything.
And so that evaluation is a vaginal exam.
That is just with one finger in the vagina, kind of being able to palpate the muscles that way.
And then you're really able from that to figure out sort of what's going on in general.
Yeah.
Okay. And then from there, you prescribe exercises.
Yeah.
And I mean, it's therapy just like anything else.
Just like anything else. You know, for some people, it's like their issue is that their muscles are too tight. And that can lead to incontinence. Because you can imagine if your muscles are too tight and they need to squeeze to hold pee in, they can't because they're already tight, like as tight as they're going to get.
Right.
Then we need to loosen them,
right,
and then re-strengthen them. For some people, the muscles are like sluggish, or I don't want to call them loose, but just like weak.
Right.
Then we just strengthen them.
Right.
So you can tell that right away.
So during my first exam, we did some kegels, and I think I said to you something like, I can't really feel, because I remember doing kegels before having a baby.
Yeah.
And trying to do kegels now, especially after so many years have gone by, shame on me. It's like flexing a muscle that I can't feel. And you said about the desensitization.
So what they found in the research is after we have a baby, you know, the muscles like lengthen, like I said, and it's a big deal to the body, like we've already said. And the brain sort of is like, whoa, okay, that was huge. And you have a baby now, right? So like, and you also have to raise a child.
Right.
And so the brain's like, this is not life-threatening. So what I'm going to do is I'm going to actually like take some of my nerve input away. I always think of it, I think I might have told you this, like in the Wizard of Oz when the house falls down, the Wicked Witch of the East in the beginning. Do you remember that?
Yes.
And like the feet roll under. That's like what the nerves do. They like retract. And so the brain's like, yeah, I gotta like do all this other stuff. This is not like threatening. And then
So it kind of shuts it down a bit?
It just like does the bare minimum. Yeah, it gives you the bare minimum amount of nerves to like function. Sort of.
Yeah.
And so what they found in research is that this doesn't just come back on its own. You have to physically relearn it and regrow those nerves to do what we need them to do. And that takes a lot of thought. It takes a lot of habit changing. It takes strengthening, like you know. And so that's kind of where we get into this.
So the kegels themselves, I know a lot of people know what kegels are. Kegels are, you know, when you tighten. You can probably explain it better.
Yeah, kegels are just a contraction of the pelvic floor muscles.
Okay.
So you're squeezing up and in.
And I know a lot of people, I was used to doing them in traffic or doing them on the subway, just to kind of just do them.
Yeah.
And that's not really the ideal.
Well, that's what I was telling you, is that it wasn't that you were particularly weak, or, you know, it's not that other people are particularly weak, it's just that our neuromuscular connection is not there. So it's not a great idea to be, like, kind of in a frenzy doing them, like, oh, I'm going to stop late, let me get 5 in here, this thing.
Right.
I actually want you to set separate time apart where it's quiet.
Yes. And it's harder than you think.
No kids, no
to get
husbands.
Quiet time.
You need, like, 7 minutes, right?
And I find that it's also easier to do on a hard surface. I mean, maybe that's
it gives you a little bit more feedback.
Feel it a little bit better, yeah.
Yeah, so that works for you. Some people it works when they're standing better, sitting. Some people it works better when they're lying down.
Right.
But
you have to be concentrated.
It's important because you're growing nerves.
Right.
That's really what you're doing.
And the other thing you told me to do was when I'm sneezing or coughing, to really focus on that squeeze.
Yeah.
Instead of, sometimes I'll just cross my legs real quick. And that's been working for me, which is awesome. So I do feel like I am sort of learning how to let my body
do it again.
Do that.
Yeah, and it's easier said than done. Sometimes, like, life happens and you sneeze and you do it across your legs.
Right.
We call it the knack, though, when we want, we're trying to, this is a habit that your brain used to do. Before you had kids, you would sneeze and your body would catch it.
Right.
Now it's like, whoa, it's like catching it off guard. So you're reminding it, I know a sneeze is coming, so here I'm going to squeeze and then sneeze.
Right.
Can't do it on the trampoline as well.
Right.
So sneezing and coughing, we kind of know that's coming.
Yeah.
That's when I want you to catch it. But like jogging, trampoline,
is just,
you got it. Like your brain has to be there for you.
Right.
That's why that's kind of the gold standard.
So the kegels themselves, you gave me very specific exercises to do, and I think most people when they do kegels are just squeezing.
Yes.
But there's more to it than that.
Yeah. So a kegel, right? Like I said, it is squeezing the pelvic floor. It is your pelvic floor muscle contraction.
And by the way, it's squeezing. This is something that I learned. We're just going to talk about it all, y'all. So don't get shy. It's squeezing both where you would, stop your pee and like your butt area. Butthole.
Yeah.
So it's that whole. It's like a figure 8, right?
It is. So it's a figure 8 that goes from your urethra, right, your pee hole, around the vaginal opening, around the butthole, and then to the.
Again. So it is really just a bigger area. It's not just that front area. It's
exactly.
The whole
I
area.
think when I'm doing a kegel, I think of pubic bone and tailbone squeezing together.
Pubic bone and tailbone. Oh, okay, yeah.
Right? So it's like you're getting it all, yeah. And you're pulling up and in. So up and in.
Okay. And then it's not, so the exercises you gave me are a little bit more in depth. It's squeezing and holding.
So a regular kegel, right, would be just like the strengthening portion of your workout. So that's just squeeze, relax. You're not holding it for any specific amount of time. You're just squeezing and relaxing. Right. And I usually have you do 30.
And that would be like doing your
bicep curls, right? And there's been research out there that shows that 30 kegels is kind of like enough to maintain. Yeah.
Okay.
So eventually.
So once you do get to the place
where you want to be, eventually 30 kegels is enough for people.
Because, guys, this is a lifetime thing. This is not a once and done thing. I'm better. You have to keep at it.
You do.
And it's worth it to not be that guy in the nursing home who's incontinent. And
I agree.
To be that guy who can, oh my gosh, running after your kids like suddenly.
Yeah. Like
your kid takes off and you're, and then you're like, oh,
yeah.
Great, yeah.
Yeah.
It's so worth it.
It makes your day like a little easier, So we got kegels, which are like a bicep curl. We have the holds, which would be like endurance, right? So that would be like a long distance run or something like that.
Squeezing a kegel and holding it.
Squeezing and holding.
Which is really hard. All right, a little technical interlude there. So we were discussing the hold type of kegel, where you just squeeze it and hold. I started at 8 seconds, and now I'm up to 16 seconds.
Yeah, we're trying.
And the ultimate goal would be
a minute.
Yeah, so I can't ever imagine being able to do that.
Yeah,
but
I know.
We'll get there.
And 30 seconds is a really good mid goal, right? And so when you started at 8 seconds, and I told you 1 to 2 1 second improvement every 1 to 2 weeks is kind of like as good as we can ever expect.
So we're talking like a half a year to a year to get there. So this is work, you guys. This is work, just like any other therapy that you would do.
Yes.
And then the next kind, we did the elevators.
So then we have elevators, which are really like our dexterity and control over these muscles. So you're trying to, we break it into like 3 parts. So you're trying to kind of like squeeze a little bit more, all the way your top squeeze, and then let go that same way, let go in 3 stages.
Which definitely requires the most concentration.
And that's where your brain, you can feel your brain on that one, I feel. So those are the elevators, and they're really just there for you to be in total control of those muscles.
Right. And then the 4th kind is the flicks, right?
Quick flicks, So the quick flicks are more of our power and our speed. They are there for you when you sneeze, cough, jump.
And that's so you can react.
Exactly.
And the quick flick is...
So they're a kegel, but you're trying to squeeze it as fast as you can, kind of snap it back and let go.
So it's
exactly. So I usually have you do them in sets of 5, right? Like 1, 2, 3, 4, 5, relax, and then
take a breath. 1, 2, 3, 4, 5.
Yes.
Yeah. So that was good, just knowing all the, because I don't think that people know that there are all these different types of conditioning that you want to do for your pelvic floor. Okay, so the one thing that I wanted to impress upon our audience is, how do they find someone like you? What are you called? Where are you found? And all of that.
So I am a physical therapist, right, and I specialize in the pelvic floor. So you're looking for a pelvic floor a pelvic floor physical therapist, and so it's not often like in their name or credentials. Often it's like in the company's name, something like that.
Right. And so you find companies called, yours is called?
The Pelvic Health and Rehab Center.
The Pelvic Health and Rehab Center.
The two best ways I would say to look for a pelvic floor specialist right now is to go on the American Physical Therapy Association Women's Health page.
Okay.
So it's apta.org.
apta.org, and we'll put that on the subtext.
Women's Health. And you can also look in the International Pelvic Pain Society. It's called the International Pelvic Pain Society, but it's for all pelvic floor specialists. So it's IPPS. Actually, we're going to have to look on the website on that.
Okay.
But the International Pelvic Pain Society has a whole list by state of pelvic floor specialists.
Right. Obviously, it's going to be easier if you live in a metropolitan area versus if living out in the woods somewhere.
Yeah.
But I think one way or another, people will be able to find somebody who's somewhat close to
so.
where
It's
they
getting
live.
more mainstream.
And number of visits, I mean, handful, maybe?
Well, yeah, it depends, obviously. But what I was going to actually say in the when we were talking about the kegels, and I'm glad we're talking about it now, is that it takes a minimum of like 8 to 12 weeks to really see a meaningful difference in your life. So the first 4 to 6 weeks of like doing physical therapy doesn't mean you're going to be in the physical therapist's office every week, but just those first 4 to 6 weeks is just your brain growing nerves.
Right.
And then 8 to 12 weeks is like your muscles are actually starting to take it on and get stronger.
And own it.
And then you have to keep doing it.
Right.
Right? And then you have to like just think, like we said, you started at 8 seconds, we want to get to 60.
Right.
It's going to take like a good year and a half, that kind of a thing.
Yeah.
So
I mean, there's a lot of damage that has to be undone here, right?
Yeah, so a lot of times I'll have you start like maybe once a week for the first 1 or 2 weeks just to make sure we've got the whole program down, and then we'll go to like once every 2 weeks for a couple weeks or a couple visits to make sure like we're still on track, and then I may say, okay, go for a month, do your thing,
right?
Let's check back in and see, just make sure we'll up the program as necessary.
Right. And then do you see people once a year? Do you have an ongoing maintenance?
And then we do, yeah. Some people feel like, I'm good.
You're good.
Right? They don't need it. Some people feel like they just want to check in and make sure it's all good.
Right.
Once a quarter, once
or they maybe
6 months.
backpedal a little bit and.
Of course, because then sometimes you just
forget.
You get cavalier.
Yeah,
of course.
you do.
And so then people will come in like once every 6 months or so, I would say.
Okay. Insurance.
Yeah.
Does insurance cover this typically?
So here's the problem with insurance. Insurance covers physical therapy, right? And we are billing physical therapy codes. The problem with pelvic floor physical therapy is that the business model has to be different, right? We have to be, one-on-one in a closed door room. Nobody helps. And so most practices have gotten away from
insurance.
Billing insurance because they're not getting reimbursed enough to like make their practice go.
Understood.
So most companies are having, we give you a super bill, you give it to your insurance, and it's billed as an out-of-network service.
Okay. And by the way, it's still well worth the money to, in my opinion, to get this stuff fixed, because, I mean, think about all the stupid things you spend money on in your life. To fix your own body and to take care of mom is super important. I know I'm really bad at it. I'll go to the mall to buy myself something, and I'll buy my kids some shoes and come home with nothing for myself. And I think that it's just so important for us to remember to take care of ourselves, and this is such an important topic for us to take care of. All right, so I think is there anything else, any other big points that we wanted to hit in this segment?
Yeah, no, I think this is pretty good.
All right, awesome. All right, thank you guys so much for watching. Please take care of your pelvic floor. You'll be so much happier. Your husband maybe will be happier.
Yeah.
We'll see. All right, signing off. See you next time. Thanks a lot.